Okay, Bismillahirrahmanirrahim. We are going to start now our palliative chapter. So, first of all, can anyone remind me what are the palliative chapters in this book? Science of Pediatrics book. I gave you one simple note, handwritten notes, that is the chapter name. Have anyone remembered that page number, chapter number?
Chapter 8, 34 and 35.
Chapter 30, 8, 34, 35. Yeah, 8, 34,
34.
35.
35. 8,
Yeah,
34, 35.
yeah. 8 is okay, yeah. So 8 is child protection. Child protection is a part of safeguarding, okay? So safeguarding we will read in our ethical class, okay? Child safeguarding and child protection, that indicate, child abuse. This indicate child abuse. So ethical class, our ethical class will consist of child abuse and protection, child protection, okay? So chapter 8 we will discuss in Sunday, okay, on next class. Okay, then next is chapter 34 and chapter 35. Okay. So chapter 34 and chapter 35, and also some chapters are in the Red Book Pediatric Guideline. Okay, you have to finish that also. So chapter 34 is purely palliative chapter. Okay, and chapter 35 is ethics. So today our discussion is chapter 34. So in the first part, I divided today's class in two parts. First part we will discuss from the book. Second part I will discuss from the notes and question. Okay, question answer session. I will ask you question, you will answer me. I will give you some scenario, some palliative scenario. Okay, these are exam scenario, recall. So I will give you some exam scenario and I want prompt answer within minutes. Okay, you have to answer me what will be the option. So today's session will be very interesting, and palliative and ethics are my favorite class. Okay, these two are my favorite class. So today's class will be maximum, I think, 3 hours. Okay, in between. So let us start from the beginning. Bismillahirrahmanirrahim. So chapter 34. Okay, the rest of the chapter are fall in the ethical class. So our next class will be the ethics. Okay, anyone have any question before I start? Any confusion regarding the palliative and ethics? Anyone? Is there any student from AKP batch? Can just you say me hi? Any student from AKP batch? No student? Hello? I actually give the notification very late, so maybe. Okay, so chapter 34.
Ma'am,
Yeah.
ma'am,
Dr. Ritika.
what does past tense means? Is
Yeah.
the questions came before or previous exam question, or what is this past test?
Okay. Past test 2019 and 2020 folder I gave you, right?
Yes, ma'am.
20. That is the past test. That is for what we buy online. That is the that is the offline version of the. Okay, it's shared in the, and the past paper, that is called recall. Okay, clear? Past paper we
Uh,
call it recall. That is the previous exam.
Recall is
These
the
are not
previous
same.
exam
Not same.
question, and past test
Yes, recall.
like
Past test is the online offline version of the question bank. Yeah. Okay.
okay.
Any other question before I start? Any other confusion? How your preparation going on? I mean, the exams are going on fully. Okay. So how your preparation going on? When I finish any class, I will expect that that chapter is finished for you also. I will expect, right?
ম্যাম
Yes.
আমরা যারা যে পরীক্ষা দিয়েছিলাম রেজাল্ট হওয়ার আগে কি ওই আপনার পূরণ করতে হবে ওই যে ওরা তো উইন্ডো এক্সাম উইন্ডো ওপেন করে দিলে তার দু একদিনের মধ্যে না করলে তো ওটা আর পাওয়া যায় না সিট তাহলে
হ্যাঁ
মানে
কোনটা দিতে চান, একেপি নাকি আবার দিতে চান?
না না,
কোনটা
আমি
দিতে
তো
চান?
পরীক্ষা মানে সব ওটা তো ফেল করবো, তাহলে তো দুইটা দিতে চাই, তাহলে তো আমি কিছু বুঝবো, তাই বলছি।
How you know আপনি ফেল করবেন? Don't do that. Expectation should be good.
না
আপনি
ম্যাম, পড়ালেখা তো করি নাই, তাই বলছি। তাহলে কি আমি এখন আগে আমার কমপক্ষে তাহলে যেটা পরীক্ষা দেয় নাই ওইটা পূরণ করতে হবে, তাই তো?
রাইট রাইট, আপনি যেটা দেন নাই ওটা এখন দেন, ওটা এখন আপনি ফিল আপ করেন, ওটার ফিজ জমা দেন। যেটা পরীক্ষা দিয়েছেন সেটা অফ রাখেন, সেটা দিয়েন না এখন, কারণ সেটা আপনি রেজাল্ট বের হোক, ইনশাআল্লাহ ইউ উইল পাস। ওকে
ওকে, থ্যাংক ইউ।
ওকে, থ্যাংক ইউ। সো আমরা এখন স্টার্ট করব, উইল স্টার্ট নাও। Okay, let us start. Bismillahirrahmanirrahim. So from this palliative chapter, okay, what is our main understanding? For many of us who are new for MRCPCH, like who did not do meetings before, who did not do the class before, okay, many of us doesn't know that what is palliative. And in our in subcontinent, this chapter is very neglected. We understand palliative means paracetamol, ibuprofen, naproxen, few drugs. We do not understand that palliative is not only a pain related topic. Palliative is the optimum comfort for a patient. It can be secretion, it can be convulsion, it can be pain, it can be distress, right? So what is the definition of palliative medicine? Can anyone just say a few words? What do you mean by palliative medicine? Puran student jara achen, the old students, please speak up. What do you mean by palliative care? Anyone?
Yes, ma'am.
Okay. Yes.
Yeah, it is just basically it is not a curative treatment. It's just to increase the quality of life in critically ill patients.
Yes. When any definitive treatment is actually not suitable for the patient, or the patient is going on terminal care illness, and the patient is suffering from terminal problems, okay, at that time we will refer the patient to the palliative care. So if I compare palliative medicine in an umbrella, have you ever heard the name of umbrella? Okay, this is the
Yes.
definition of palliative, the definition of palliative care. You see, palliative care refers to the support healthcare can offer where cure is not possible. Palliative medicine refers to the contribution that doctors can make to that care. That means I can give optimum comfort to my patient, okay, before death. Some may die early, like within 1 or 2 days, okay, in severe acute condition. Some may die later, like 1 year, 2 year. Suppose neuroblastoma, stage 3, stage 4, leukemia with severe metastasis in the multi-organ failure, when the curative treatment is not possible. There is no curative treatment, or repeated chemotherapy failed. In these cases, the child, what problem the child will suffer? The child will suffer from pain, number one, will pallor, infection, features of bone marrow failure, fever, secretion due to obstruction. Okay, so these are the terminal complaints a child will face. So to combat those problems, I will refer the child to the palliative team. Now, what are the people? Who are the people that are in the palliative team? What is palliative care actually? So we know the definition, but we don't know exactly what is palliative care. So see this box, what is palliative care? Okay, the screen is good to you, the screen? Okay.
Yes.
So the
Yes,
palliative care is aimed at improving life. Okay, thank you. The palliative care is, that means improving the quality of life, not the quantity. Remember, this is the first line, not the quantity. I cannot give new life, or I cannot give extra days to the child, but I can give him some comfort. at the terminal care. Okay, consider all aspects of life, including psychological, emotional, spiritual. Okay, so some people think that palliative care means I'll give medicine, I'll give secretions, I'll give suction, I'll give ventilation, I'll give like this, I'll give like that. No. Palliative care means I'll give full support, not only the child, also the family, also the caregiver. Suppose the grandmother is the caretaker of the child and the child is going to die. So to give the support to the grandmother is also my duty. Got it? So this is called palliative care. Not only physical, but also psychological, emotional, and spiritual aspect. Now, what do you mean by spiritual? What do you mean by emotional? Suppose a Muslim family, they are crying because their child is going to die. They're crying and they are, they want to pray at the hospital. So who will arrange the prayer? There are some religious leaders in the hospitals, like imam, like priest, like pandit. Okay, every hospital, not only every hospital, but the big hospitals where this palliative care is provided, that hospital has this religious leaders. Okay, suppose a mother lost her baby at 1 month old baby, and the mother is crying at midnight. Okay, who will give comfort to the mother? Okay, suppose it is a single mother, or maybe parents are there. So who will give comfort at midnight? So there is a 24-hour telephone service. Mother will call, or the father will call the telephone service, and they will give comfort, face-to-face meeting or telephone care. Okay, so this is a total team of palliative care. Now, among this total team, okay, some people are also volunteer. Remember, not only the paid people. Some people act voluntarily, okay, without any benefit. Okay, so this is the palliative team. Every country, okay, have some sort of palliative team. Okay, I do not see the chats. Okay, please message me. Don't message me, just talk. Okay, I cannot see the chats. Okay, so this is palliative care. Consider the need of the family. That means even after the child died, the family needs support. So we will give support. This is we call palliative care. And intervene only when the benefit of intervention outweighs its burden. So suppose I will give benefit, I will give ventilator, I will give CPAP, but up to when? Now this is the ethical issue. Suppose a child of 22 weeks or 23 weeks and a child of 36 weeks, there is only one ventilator. Both the child needs ventilator. Now tell me, which child you will give the ventilator? Suppose in the whole area there is only one ventilator
At
and you cannot
36
refer.
weeks.
Huh?
The 36 weeks one?
Why?
Well, because there is more chance
Yeah,
to
why?
survive.
So what is this called in our ethical definition? What is this called? There's a term that is called justice. You remember justice? This is the justice that I will give 36 years old child to the ventilator. Okay, because 23 weeks or 22 weeks, what is the data? What is the data saying? Data saying less than 1% chance of survival, right? And below 23 weeks, according to the definition, it is called abortion, below 23 weeks. So here, intervention should not be outweighs its burden. So I will not give ventilator to a 23 weekers when I can give this ventilator to a 36 weekers. So this is the called ratio. You have to make justice. You have to see the ratio. Okay. It is a multidisciplinary approach. Remember, there are religious leaders, there are chaplains, there are hospice care, there are doctors, there are nurses, there are palliative nurses. Okay, there are loads of people are associated with this palliative team. Palliative care does not mean withdrawal of the care. It does not mean euthanasia. It doesn't mean left after medical treatment has failed. When medical treatment failed, I will give you palliative. No. it means the child is in terminal condition and the child needs comfort. Needs comfort. Okay, suppose a child who is okay till now, but 2 times or 3 times treatment failed, leukemia treatment failed, I will give them palliative care? No, I will wait until the child needs that care. Okay, this is an assessment that this child will need palliative care. This is an assessment. And who will do this assessment? There will be a board meeting. There will be a consultant, registrar, okay, the nurses, the palliative team, okay, all these members, suppose oncologist, neurologist, or endocrinologist, all these members associated with the care of the child, they will be in the meeting and they will decide that yes, this child needs palliative care. Okay, so remember, palliative care doesn't mean self-death. Okay, let my child die. No, this is not palliative care. Okay, I want to die. Suppose a 15-year-old child telling you, I want to die. This is not a palliative care. And a child who has survival chance, you will withdraw the ventilator. This is also not the palliative care. Okay, so which one is palliative care and which one is palliative care not? Which one is not palliative care? This you have to understand. Okay, and in the palliative care, when you will refer to which specialty? Now I will tell you what do you mean by palliative care. Okay, so see, this is the umbrella. Okay, this is the umbrella. My drawing is horrible. Okay, this is the umbrella. It looks like umbrella or not. So there is some branches in the umbrella. Okay, this is the palliative umbrella. Suppose umbrella is the palliative care. Now there are some branches. What are the branches? See, here will be symptomatic management. I will give symptomatic management. I will give advanced care. Suppose a palliative child needs a surgery. Who will give this surgery? Advanced care management. Okay, then I will be to the religious leaders, okay, chaplains, then to the hospice care, okay, hospice care, then a child who needs who needs burial after death and who needs post-mortem. If there is child abuse, needs post-mortem, who will do these things? Coroner's request, okay, coroner's inquest actually. So these are the palliative team: symptomatic management, then advanced care, then chaplains, hospice care, and coroner's inquest. I will give you another arrow, some more example of palliative team. Okay, so understood what is palliative care? I hope you understood. Suppose a child who is, okay, let me finish. Some people are joining, sorry. Why you are late for the class? See, so this is the palliative team. Okay, now RCPCH has a proper training. Okay, RCPCH has proper training and proper management. This is a specialized branch in pediatrics and in adult. So pediatric palliative team, adult palliative team, different. Okay, so pediatric palliative care. Okay, when you are working in UK, you will be taught. And if you are interested, you will be given higher training in the palliative team. So you will become the lead of the palliative team. Okay, so this is the palliative training. Now some people exhibit the, like suppose a child who is 3 years, 4 years, verbal child. What he will tell you? Mom, I have pain. Or mom, I cannot swallow. Okay, or mom, I have headache. Okay, this is the complaint. Or mom, I have blurring of vision. So a verbal child can tell his problem very clearly. But how a child who is non-verbal or a neonate, how they will present? Okay, in what complaint they will have? Okay, suppose crying is a evidence that the child is in pain. Then the child will become quiet and withdrawn, frowning, grimacing, facial expressions. Okay, seizure is increased, spasm is increased. The child previously fed on orally, now he cannot. We are giving by nasogastric tube or orogastric tube. hypersensitivity to stimuli, it indicates nerve excitement, it indicates pain, a change in posture or behavior like head banging or rubbing, increased flexion or extension movement. These are the evidence that the child is in discomfort, okay, in a non-verbal child or neonate. Now, I told you before, palliative care doesn't mean you will increase the duration of life. Palliative care means you will improve the quality of life, and it involves usually in the terminal care. So, pain is the first complaint of a child who needs palliative. Like, pain can be due to any reason. It can be due to neuroblastoma, leukemia, lymphoma, or any rupture on a viscera, or neuropathic pain, So, pain pharmacology. Okay, we have a chapter in Red Book, pain pharmacology. Okay, especially which drug? Morphine. Okay, morphine have different form like synthetic morphine, semi-synthetic morphine, natural morphine, codeine. There are different forms. So you should know the pain management, especially the morphine. Every kind of morphine, mechanism of action, side effect, strength, how you will convert morphine, oral morphine to the subcutaneous morphine. Okay. So now you have to be a very good knowledge about the pain pharmacology, and pain improvement of the pain. You see that the child will dramatically improve. The child, 80% problem will go if you can improve the pain. Okay, so pain is the most unpleasant sensation in our body. Okay, in any condition, it can cause emotional distress, and it can cause tissue damage. Okay, so there are some classification of pain, criteria and staging. WHO pain ladder. We will teach you in after few moments. There is a pain ladder in WHO. So according to the pain ladder, how you will see this pain ladder? By the facial expression, the child is crying, with pain. So pain mainly complained by subjective complaint, and then by objective. Subjective means whatever the child says to you. This is called subjective complaint. Okay. So pain pathway, you have to understand the pain pathway and what is the, what pharmacological treatment I will give for that pain, particular pain. Suppose there can be, compression pain, there can be rupture pain, there can be neuropathic pain, there can be burn pain due to burn sensation, there can be pain due to what is that called, bone marrow invasion. Okay, so there are many kind of pain. Okay, now let us see assessment of pain. So whenever the child complains pain, you will examine the child, you will take the history, okay, what type of pain it is. Like in MRCPCH part 1, you will be given a short scenario, like the child has burn and there is 40% burn. Now the child is screaming with pain. Which one of the following is the best painkiller for this child? Okay, so pain medicine is just like that. So you have to understand what type of pain it is, okay, and how we will give treatment and which one is the best treatment for the child. Okay, suppose a child having mild limb pain, he does not have leukemia. So what type of painkiller you will give? Oral ibuprofen or paracetamol? Mild pain. But same child having pain due to leukemia or neuroblastoma, and the child is crying to pain, you will not give oral paracetamol or NSAID. Yes, first stage you can give, but when the pain is not improved, you have to go to codeine. If the child does not improve by oral codeine, you have to give subcutaneous codeine, subcutaneous morphine, or IV morphine. So like this, you have to understand what is the pain classification and what is the pain staging. Okay, so there is a phase tool. I will show you the picture in after a few minutes. This is the called phase tool, phase type tool for observation of the pain and classification of the pain. I will show you what is that. Okay, now management of pain. Consider and treat specific reversible cause. Like like any child who has constipation, gastroesophageal reflux, orthopedic pain like DDH, hip dislocation, this kind of pain is reversible. If you treat the cause, the pain will go away. Some pain you will give non-pharmacological measure. What are those? Attention to reversible cause of fear and anxiety. Some children, they have pain, but they cannot actually tell you, okay, and they have so much anxiety about the pain. So if you counsel the child, if you talk with the child, then it will be very easy that the child will have less pain. So talking with the child reduces the pain, remember, reduces the anxiety. So that is why doctor should be talkative, he should be talkative, he should be a little bit of extrovert, a little bit of I can say, understanding. Okay, so you have to talk with the child, then it will remove the anxiety. And this is the scenario we practice in our clinical exam, okay, that we talk with the child, okay, about the pain. Okay, there is a FOP cases book, okay, FOP cases book for palliative care, that is very important. Okay, so key point here, some non-pharmacological measurement for pain is, you have to give attention to the reversible cause, fear and anxiety, then hot or cold pack, acupuncture, okay, then distraction technique, like if you distract the child by some playing method, this is called, pain reducing technique. There is a play therapy, okay, behavioral technique like cognitive behavior therapy, relaxation, visualization, and art therapy. Some children have feel very much relaxed when they saw art, when they do meditation. So these are the relaxation technique to reduce pain. Any question until now? Anyone did not understand any point? So from the pain, we have to understand two things. Number one is pain phase, and number two is pain ladder. I will teach you what is pain phase and what is pain ladder in a few moments. So WHO ladder, it is based on the uh, on this basis, on this ladder, we manage pain in the palliative care. It expressed the concept that increases in the intensity of pain should be matched by changes both in type of analgesic and manner of the prescription. That means when the child will tell you that he is in pain, you will have to change the prescription. Okay, you have to trust the child. So there are 3 steps of WHO pain ladder. Okay, like each step is characterized by a specific classification of the drug, a specific dose, like regular versus needed, and need a considered adjuvant. Now, what is adjuvant? I will tell you. This is the question. What is adjuvant? What do you mean by regular dose? And what do you mean by needed dose? Okay, I will advise you to log out and then join again. Who cannot hear me, okay? Because everyone can hear me, right? Guys, can you open your mic? I am audible?
Yes,
Yes,
ma'am.
ma'am.
Clearly audible.
Yes, ma'am. Yes, ma'am.
I think some people have network problem. Please log out and then again join, okay? Okay. Next. So until now is clear to you what is palliative care, I think. It is very easy, right? It's not so much hard. So when you are giving a child of this one, like when you are giving the child to the painkiller, remember there is some dose that is called regular dose. There is some dose that is called as needed. As needed means PRN. Like when you will feel that the child needs more dose, extra dose, that is called PRN. PRN means when the child is in pain, I will give extra dose. Okay.
In Bangladesh, it is called SOS, তাই না?
ঠিকই আমরা এসওএসই জানি আসলে আমরা পিআরএন জানি না but when I gave MRCPCH, okay, I am a fellow from Bangladesh. FCPS already done in 2013, almost 8 years, and I found very improvement in the knowledge, in the in the understanding better way in pediatrics. Okay, then I feel that if there was another degree, then I will find it that also very interesting, because that is more beneficial. Like, each country has some benefit. So here in the MRCPCH, we will come to know that pain management depends on the staging. Okay, so a few days back, I had a incident that I gave some painkiller to some child, and I was actually criticized why you gave that painkiller. And but actually I failed to make that person realize that painkiller depends on the grading of the pain. Okay, a child who is screaming with pain, you cannot give IV paracetamol. There is no IV paracetamol in the pain ladder. If you see the pain ladder today, there is no IV paracetamol. So we know only paracetamol. We don't know that there are many, many painkillers. Okay. So I did not actually argue. I did my job. The child became improved and discharged. Okay. So this is my job. I did my job. So that is why I will make you understand that today you will come to know that pain killer should be given according to the classification, not according to the our knowledge. Like, we know only paracetamol, we will give only paracetamol. No, there are many, many painkillers, and you can use them with monitoring. Like morphine, if you give them, you will monitor them. Okay, no problem, you will monitor them. Okay, so this is the painkiller, and I will tell you what is adjuvant. Adjuvant is a medicine, or that is not an analgesic. Remember, this is not an analgesic, but used alongside analgesic. Okay, its action can reduce the pain in certain specific situations. So you will not use adjuvant in every situation. Remember, in certain specific situation you have to use the adjuvant, and it is not an analgesic. It is a kind of other drugs or other intervention. What do you mean by intervention? Suppose hot bath or cold bath, this is an intervention. Suppose radiotherapy, this is an intervention. We give radiotherapy for bony pain, right? So this is not a medicine, but this is an intervention. So these are called adjuvant. Now this is the analgesic criteria. Can you see here? Suppose my child, my patient was in moderate pain, and I gave him opioid, and I was criticized heavily criticized. Why I gave opioid? The pain scoring was 8 to 9. The child was screaming with pain. Okay, and one person said, why you did not give IV paracetamol? I followed actually NICE guideline that IV paracetamol is not in the NICE guideline. And paracetamol is not a good painkiller. Paracetamol is a, very weak painkiller. See here in the mild pain, simple analgesic, you can give simple analgesic like paracetamol, ibuprofen, only in the step 1. What do you mean by step 1? Up to stage 3, pain criteria 0 to 3. When it is 4, you have to give opioid either orally or IV. This is 4 to 6. When it is more than 6, 7 to 10, you have to give IV continuous or subcutaneous in severe pain. So my child was actually in the criteria was 7 to 8, like 9, 7, 8, 9. So this was step 3. So remember, whatever you know, okay, whatever you know, you should know properly. Half knowledge is more dangerous than the ignorance. Half knowledge is dangerous because you are doing harm to your child, to your patient. Okay, clear? Huh? Okay, so now this is the pain ladder. Okay, this pain ladder, WHO analgesic ladder, it depends on the scoring. So step 1 is 0 to 3, step 2 is 4 to 6, then 7 to 10, step 3. And see, what do you mean by breakthrough dose and what do you mean by background dose? Can anyone tell me 2 line or 3 line? What do you mean by that? Can anyone tell me? What do you mean by breakthrough and what do you mean by background?
Background is, is a constant dose painkiller which we gave to the patient to relieve the pain. And breakthrough is in between that time, the dose which we gave. in between pain.
Very
If it
Basically,
increase.
background is maintenance dose and breakthrough is SOS.
Very good. So which one is PRN here? PRN dose.
Breakthrough.
PRN is breakthrough.
SOS.
Breakthrough. Yeah, ma'am.
Yes. Yeah. And background is
Maintenance dose.
continuous.
Continuous. Yeah.
Maintenance dose. Yes. Continuous or long term. Suppose you are giving a long acting drug, BD, double time. This is called background dose. Suppose you are giving long acting insulin. This will be background. Okay, and you are giving short acting actrapid. This is called breakthrough. You understood? So accordingly, morphine has background and breakthrough. Like you are giving long acting morphine 12 hourly. This is called background. And the child felt pain in between these two doses. You have to give another extra dose. This is called breakthrough, PRN. Okay, so remember, PRN is countable. It is not uncountable. You can give maximum 20 to 30% of the total dose. You cannot give as much as you need. No, the child will go into respiratory depression. Morphine has some side effect. Okay, so you cannot give as much as you need. You have to give a specific amount. You got my point? So this is called breakthrough dose. Now, what is breakthrough dose? What is background dose? Which one is subcutaneous dose? Which one is intramuscular dose? These things you have to understand clearly. You have to have a clear idea. See, opioid, if you give orally, you can give 0.1 milligram per kg. Orally you can give. Okay, if you want to give IV, okay, then starting dose is 1 milligram also, 1 milligram per kg, 12 hours per day. Okay, and among this dose, suppose the child is 10 kilo, then you are giving 10 milligram per day, suppose 10 milligram per day. 1/6 or 1/10 dose will be background dose. Of total daily background dose is the breakthrough dose. So the child is getting 10 milligram per day. So 1 milligram, 1/10 milligram will be the breakthrough dose. 1 milligram, you can increase 1.2 milligram like this. 1/6 to 1/10. Clear? 1/6 to 1/10 you can give as a breakthrough dose. So there is a limitation of breakthrough dose. Okay, and breakthrough dose you can give how many times? Okay, you can give 1 hourly to 4 hourly. Okay, but we don't give 1 hourly, we actually give 4 hourly like this. And if the child needed more breakthrough dose, we increase the background dose. We increase the background dose because background dose is not suitable. Background dose is less than the child actually needs. Okay, so remember, this is called breakthrough and background dose. Any question from this? See, these lines are very important. These lines.
Ma'am, if I given a background dose stat of person, if he needed any pain or relieving thing, then we give it again the dose if the maximum dose is completed.
আচ্ছা, একটু বাংলায় বলেন আবার।
আচ্ছা, যদি এখন ব্যাকগ্রাউন্ড ডোজটাকে দিয়ে দিই, যদি মাঝখানে আবারও 4 আওয়ারি বা 6 আওয়ারি পরে তার যদি আবারও পেইন হয়, তাহলে তারপর ম্যাক্সিমাম ডোজটা দিয়ে দিলাম 1 মিলিগ্রাম পার কেজি করে। তারপর কি আমি ওকে আরো কিছু ডোজ দিতে পারবো?
Right, very good.
Finish my dose.
Yes, you can. Because background dose, even if you have given 1 milligram per kg per day, suppose BD, you have given, but you can give 1/6 to 1/10 of this dose as a breakthrough dose. Yes, and suppose you are giving 4 hourly breakthrough dose, then the child is not relieving pain. That means your background dose is minimum. You should increase the background dose 30 to 40%. You can increase next day. Clear? So background dose will be increased on next day. At the same time, breakthrough dose will be decreased because the child will not need breakthrough dose because you already increase the background dose. And if orally is not suitable, I will give subcutaneously or IV or IM. Okay, so
Which is the oral only? Codeine is oral?
Yeah, codeine is oral. You don't give codeine IV. There is no codeine IV.
Only oral is
Pethidine is IV. Pethidine is IV. Yeah, only oral. No, oral morphine is there. Oral morphine is there. Oral codeine is there.
Okay.
Okay. Okay, oral morphine
And ma'am,
is
the
there,
dose
oral dose,
of
oral
all
dose.
of these are 0.1 mg per kg. That is same
Yeah, for
of the
oral, yeah. Same.
oral.
But there is a contraindication of codeine. Yeah, you remember contraindication of codeine? What is the contraindication?
Respiratory asthma,
No, below 12 years. Below 12 years.
ma'am.
Below 12 years.
Yes, ma'am.
Sorry,
Why?
ma'am. Can
Can anyone tell me why
Ma'am,
codeine
sleep
is
apnea.
contraindicated below 12 years? Apnea. Okay. But who can tell me the exact reason why codeine is contraindicated below 12 years?
sorry, ma'am. Contraindicated in
Below 12 years. Codeine is contraindicated below 12 years. Okay. Why? I'm telling you. Because codeine is going to the body. Okay. Sorry, I cannot hear you. Sorry. Okay, maybe your mic is network is not so good. Okay, network is not so good. Okay. Okay, so codeine goes into the body. Okay, codeine goes into the
Or in
body
high
and then
doses?
it I did not hear you. Your network is not good. Codeine goes into the body. Okay, then it convert into morphine because it is a prodrug. So how much codeine will be converted into morphine? This is uncertain. The metabolism is uncertain. So suppose you are giving 1 TSF of codeine. How much morphine you will get? You don't know. That is why below 12 years, codeine is contraindicated because the metabolism is not mature and I don't know how much codeine will be transmitted into morphine and I don't know the child will go into respiratory depression or not. Okay, but above 12 years, you can take the risk. Okay, so orally I can give morphine, orally I can give codeine. So what are the simple analgesia? Paracetamol, NSAID, aspirin. These are the simple analgesia. What are the opioid class of analgesia? Morphine, diamorphine, fentanyl, buprenorphine, methadone. So these all are morphine. Remember, opioid group. Codeine is no longer recommended in most places owing to pharmacogenetic variation in its hepatic activation to morphine. So I don't know how much codeine will go into my body and will be metabolized into morphine. I don't know. That's why codeine is now not recommended in many places. Tramadol is an opioid but has additional non-opioid analgesic property that make equivalent to morphine, but it is often poorly tolerated. So tramadol actually causes severe gastric irritation. Okay, so tramadol is poorly tolerated, but it has some opioid action. Okay, so tramadol also good, but the problem is tolerance. We cannot tolerate tramadol. So morphine is best for orally. We do not use codeine nowadays. So morphine, there is diamorphine, there is buprenorphine, methadone. There are severe varieties of morphine. Okay.
ma'am, there is this
Next.
folcodeine which is used in this cough
So
syrup. Folcodeine. So that is also an opioid, no?
yeah, that is yeah,
So that
yeah, that
also
is
has
also
an
an opioid.
analgesic effect.
Yes, and cough syrup is not a yes, yes, yes. That also has analgesic effect. Yes, you are very good. That codeine, actually, that's why that cough syrup that contain codeine is not recommended over-the-counter drug. Okay, only by the prescription of a physician you can take this because it convert into morphine. Clear? So here, this is the adjuvant list. Very, very important. Please make it star mark. Make it star mark. Very, very important chapter. This depend on the characteristic of pain, like bony pain. Okay, there is bony pain, there is nerve pain, muscle spasm, cerebral irritation, neurolytic, and other intervention. Okay, so what do you mean by bony pain? Suppose pain due to leukemia, neuroblastoma, Okay, rhabdomyosarcoma, osteosarcoma. First of all, you will try with NSAID like paracetamol, ibuprofen, naproxen. Then you will go with radiotherapy, bisphosphonate, especially if the patient has osteopenia. So in which condition we will use it? Osteogenesis imperfecta. Steroids. If it is due to metastatic lesion, suppose neuroblastoma, leukemia, you can use steroid. Okay, IV or orally. Now, some pain are related with nerves, like neuropathic pain, like, due to compression of the tumor in the nerve. Okay, that time, first drug is anticonvulsant. Okay, then antidepressant, then NMDA antagonist. This is an neurotransmitter. Okay, the NMDA is related with pain. So you will antagonize it by giving ketamine, methadone. This question came in exam, okay? This every line came in exam. Bone pain, treatment was radiotherapy. There was osteopenia, so treatment was bisphosphonate. There was steroid, nerve pain, NMDA, antagonist, ketamine, everything came in exam, every line. Sometimes you can give baclofen. Baclofen we use in which condition? Science of Pediatrics book. Baclofen we use in which condition?
Cerebral palsy.
Remember?
CP patients.
Yes, CP patient, yes. Then steroid you can use nerve pain, especially if it is causing edema, like suppose there is a superior vena cava syndrome, or suppose there is superior mediastinal mass, it is causing pressure and edema, you can use steroid. Then muscle spasm, you can use baclofen like CP child. You can use benzodiazepine like diazepam, botulinum toxin. This every question is important, every line. Then cerebral irritation like phenobarbital. When suppose there is a tumor, intracranial tumor, and it is causing irritation, what drug you will give? Phenobarbital and benzodiazepine, anticonvulsants. Neurolytic and other intervention like regional nerve block. This question came in exam, that a child having head injury and femoral fracture. Now, to give splint or cast, you need an analgesia. What type of analgesia you will give? You can't give morphine because the child has head injury, contraindicated. You cannot give morphine. So you have to give regional anesthesia, regional spinal block. Okay? Any question from here?
Ma'am, baclofen in nerve pain, ma'am, which example you gave?
Baclofen in nerve pain.
Which condition we gave? In nerve,
Yes,
which?
pain condition, like any tumor that is compressing the nerve, any tumor. And suppose there is some tumor in the spinal cord tumor that is compressing the nerve, and there is developing spasticity. You can use baclofen. It will
Spasticity, I think.
yeah, as well as it will reduce the nerve pain, both.
Okay, ma'am.
Okay. So here, this is very important. What is MST? This is slow release. Okay, write it down. This is slow release. MST means slow release. So there is some prescription of major opioid, like you have to initiate the drug, then titration of the drug, then maintenance. What do you mean by titration? What do you mean by initiation? Do you have any idea, anyone? What do you mean by titration of the drug?
Titration means we
Dose
modify the
adjustment.
dose accordingly, decrease or
Yeah.
increase.
Modify the dose. Yeah, you can
According to the
increase
pain
or you
scale.
can decrease. Yeah, according to the pain scale. This is called titration. And what do you mean by maintenance?
Once the dose is adjusted, we'll put on maintenance.
Yes, when the dose is adjusted, we will put an adjustment. Then there should always be both regular background and as needed. This is called PRN or breakthrough. Same name, as needed, PRN and breakthrough. Same. Everything is same. This is type in the group. Someone please type in the group that log out and join again. Okay, log out and join again. Please type in the group, our group, because there is some network issue. Okay, so you understand initiation, you understand the titration, and you understand the maintenance. The opioid can be given as immediate release, like See, this is very important line. Which opioid is in immediate release, which opioid is continuous release, and which opioid is delayed. So immediate release is oromorph, buccal diamorph. Very, very important line. Oromorph, buccal diamorph. Then continuous release. Which morphine is continuous release? MST. MST. And then MST means slow release. That is why it is continuous release. You know what is slow? That is continuous. What is rapid? That is stat. So this is continuous. MST, transcutaneous patch, like fentanyl patch. You have seen the fentanyl patch? Anyone giving in the patient fentanyl patch? Have you seen? No one? Have you seen any patch given to the patient? Like when we were small, you remember? Our parents or grandparents used to give patches at forehead in the temporal region. That is the painkiller. You remember that one? Like some drug that was in the patch and it is put in the forehead in the temporal region. Okay, I remember in Bangladesh it was very popular for painkiller. And that contains
No,
some
one type.
menthol, you know. Yes, one type. Okay, so that contains some menthol and some, you know, ibuprofen. So the pain goes because it is systemically absorbed. Okay, this is called patch. So fentanyl patch is a very popular drug to relieve the pain. Okay, now syringe deliver, there is subcutaneous syringe deliver. Okay, subcutaneously we can deliver morphine. Okay, and it is very painless. Subcutaneous is painless and it is very effective. And as needed dose. As needed means PRN or SOS, okay, or breakthrough. So this is a specialized skill and should be undertaken in discussion. So what type of analgesic you will give? In which type of pain? This is a very specialized skill. As a registrar, as a SHO, I cannot give. It will be given by the palliative consultant or at least the pediatric consultant when the child needed this pain, this painkiller. Any question until now? So
Ma'am,
we
can
finished the
you
pain.
explain titration again? Hello.
Titration means, yeah,
Yeah.
titration means when you given dose like 1 milligram per kg, okay, suppose the patient feels free of pain, you think that you should reduce a little bit, then you give 0.8 milligram per kg per day and you find that the child is still okay, then you will reduce the dose 0.6 milligram per kg per day. You find the child is now having pain, that means the child need at least zero 0.8. You got my point? This is called titration.
Like it's tapering and then stop at certain point.
Yeah, but not whole certain point. Yeah, on kind of that. Like you will taper until the child feel comfort, or you will
Okay.
increase until the child feel comfort.
Okay, fine.
Suppose you are giving 1 milligram per kg per day, the child does not feel comfort. You can increase 30% on next day, and you
And
see the
that
child.
dose then we will continue. Like it's
Yeah, we
called
will.
titrated dose.
Yes, you will maintain the dose. Yeah.
And but if child is again increase the pain, so we increase the dose again.
Yeah. So
Okay.
I will now stop the share from YouTube. Okay. I hope you like this. Inshallah, I will come in next class with the next topic. Let me share it.